of the clinic pharmacist, primarily working with our leukemia and stem cell transplant group. We'll be reviewing leukemia-targeted oral agents this morning in the first half of the hour. A few objectives today. We'll review indications and classes of oral chemo agents, identify relevant adverse effects of each class and agents within those classes, and then delineate key interactions, dosing, and administration pearls. So we'll review today BCR-ABL inhibitors in CML and pH-positive B-ALL. We'll review JAK inhibitors in myeloproliferative neoplasms, and then agents used in acute leukemias, including FLT3 inhibitors, IDH inhibitors, menin inhibitors, and retinoic acid derivatives. So starting with BCR-ABL inhibitors, a little bit about the mechanism. So BCR-ABL is a fusion protein that results from chromosomal translocation between chromosomes 9 and 22, and this is also known as Philadelphia chromosome. This results in a constitutively active tyrosine kinase, which then leads to uncontrolled cell growth. BCR-ABL is most commonly associated with CML, where CML is almost universally pH positive, but can also be seen in ALL, most commonly pH positive B-ALL, and it would be rare, but it could also be seen in other malignancies. I want to call out the mechanistic difference between our more traditional TKIs and the newer CML TKI, asciminib. So imatinib, dasatinib, nilotinib, bosutinib, and ponatinib are all ATP competitive TKIs, and so they'll bind to the ATP binding site and leading to competitive inhibition of BCR-ABL, whereas asciminib binds to the myristoyl pocket of BCR-ABL to cause allosteric inhibition of the protein. Asciminib is also known as a STAMP inhibitor, which stands for specifically targeting the ABL myristoyl pocket, and this one is a first-in-class STAMP inhibitor. So at the moment, all of these TKIs are approved for use in CML, but only imatinib, dasatinib, and ponatinib are approved for use in pH-positive B-ALL. Asciminib is being studied for use in that space, and so you may see this used in B-ALL in the future. We often think about our ATP competitive BCR-ABL TKIs in terms of their generation. And so imatinib is a first generation TKI, dasatinib, nilotinib, and bosutinib are second generation, and then ponatinib is third generation. In terms of dosing, what's presented here is the dosing for chronic phase CML. There are different dosing recommendations for accelerated and blast phase or for mutated CML. I want to call out nilotinib is the only one here that's dosed twice a day, whereas the rest are dosed once a day. Asciminib does have a twice daily dosing option, but the once daily dosing is preferred to start with for adherence reasons. Imatinib and bosutinib are two agents that are going to require renal adjustments. All of these except for dasatinib and asciminib have hepatic dosing considerations. In terms of food interactions, ponatinib is the only one that can be taken without regard to food. Imatinib and dasatinib, generally we recommend taking it with food to reduce GI upset, but doesn't have to be for absorption reasons. Bosutinib is one that should be taken with food to aid in drug absorption. And then nilotinib and asciminib are the two agents that need to be taken on an empty stomach. So something to keep in mind when you're thinking about adherence, especially with twice daily dosing. Moving on to notable drug interactions. So imatinib does not have any major drug interactions to call out. For our second generation TKIs, we do want to be mindful about concurrent use with H2RAs like famotidine and PPIs. For dasatinib, H2RAs and PPIs should be avoided entirely. This would be a category X drug interaction, so avoid. TUMS could be used if there was a need, but should be separated by at least a couple of hours. And then nilotinib and bosutinib are impacted by H2RAs and PPIs, but prescribing information will say you can take these as long as they're separated from the TKI. But if possible, it should be avoided as there is data to show there is an impact on drug absorption. And this can be a challenging drug interaction to navigate since there are quite a few patients that require use of some sort of antacid, and something that I do provide education on since these interacting drugs are available over the counter, just to make sure patients are not starting these up after they start their CML TKI. And then asciminib here is contraindicated entirely with atorvastatin and rosuvastatin probably are the most common statins that are being used. And so when somebody, and that would be at any dose. And so when somebody is starting asciminib and they're on one of these statins, we do change their statin. Moving into side effects, so some class toxicities likely related to the effects of BCR-ABL. Bone marrow suppression will be seen with these agents to some degree, and also rash. Each agent does also have unique off-target effects, so that each agent does have a more distinct adverse effect profile that we'll review here. So starting with imatinib, many of these agents can cause some sort of fluid retention in different fashions. With imatinib, the fluid retention that we think of is periorbital edema. This one does also tend to cause nausea, and again, that's why it's recommended to be taken with food. And then you'll also see perhaps some rash or musculoskeletal pain. For dasatinib, the fluid retention that we're thinking about comes in the form of pleural or pericardial effusion. This would be a side effect. If seen, we would not retrial the drug. There's also a risk for pulmonary arterial hypertension and also platelet inhibition, where we do sometimes have to change therapies for thrombocytopenia related to the TKI. For nilotinib, this one can cause QTc prolongation. So we do get baseline EKGs and then also periodically thereafter. And then the package insert does have recommendations for dose adjustments for QT prolongation. And then other cardiac toxicities unique to nilotinib would be peripheral arterial occlusive disease. And then there's also a risk for pancreatitis and metabolic syndrome with this one. For bosutinib, it's the newer second generation agent, also has a risk for fluid retention, both effusions and peripheral edema. But what bosutinib is sort of known for is for the GI toxicity, specifically diarrhea. So that's one thing that comes to mind when we're talking about bosutinib. There is also a risk for hepatotoxicity with this one. Ponatinib, as a reminder, is a third generation agent, probably has the most potentially serious toxicities. There is a boxed warning for ischemic reaction, arterial occlusive events, and hepatotoxicity. I think it's worth mentioning that we do have in our treatment plans for ponatinib, we have a statin built in there as a supportive med and a baby aspirin built in there as a supportive med. Not necessarily recommended by the package insert, but has been included in our treatment plans for that cardiovascular risk reduction. Hypertension is another adverse effect with a fairly high incidence, reported at 30 to 50%. And then pancreatitis is also something that we're concerned about. So we're monitoring lipase and amylase with this agent. And then I think it's worth mentioning that to limit toxicity risks, there are dosing recommendations in the labeling to reduce the ponatinib dose following a response when used in CML. Asciminib, the last one here, is fairly well tolerated. Aside from the hematologic toxicities that I previously mentioned, a couple of side effects that we're monitoring for are musculoskeletal pain and pancreatitis, typically asymptomatic, although these are not very common side effects when thinking about side effects. There was a phase 3 trial called the ASK4 first trial that was published last year, where asciminib was compared to investigator's choice TKI, and the TKIs used were imatinib and the second gen TKIs. And the data showed both superior efficacy with asciminib compared to the other TKIs and a more favorable side effect profile. And so this trial really has changed practice where we are seeing asciminib used more in the frontline therapy or as a second line agent after trying a second gen TKI like dasatinib. There are also studies ongoing for use in Ph positive BL, so you might see this in the future. Thinking about adherence, so in oncology, it's presumed that there's more adherence in general because of the perceived hazard linked to cancer, but studies show that this isn't necessarily the case. And adherence to TKIs and CML is so important because this is a chronic disease treated with daily oral chemotherapy, and there's a lot of data linking adherence to clinical outcomes. So there's data showing that non-adherence to imatinib contributes to cytogenetic relapse and poor responses. And adherence is typically defined as taking a medication as prescribed for 80 to 85% of the time. And so to put that into perspective, that's about 4 missed doses per month or 1 missed dose per week. So it's really not that many missed doses to say somebody's not adherent. And then lower adherence is often associated with younger patient age, adverse effects. And so managing these adverse effects is important. Higher doses often correlating with more side effects. And then also cost. So high copay. Sometimes folks are not wanting to stretch out their supply and may think that taking it fewer would help stretch out that supply. So one quick assessment question. So QR is a 27-year-old male starting on nilotinib as first-line therapy for CML. He's noted to have a suboptimal response to BCR-ABL testing. Which of the following may contribute to his suboptimal response? So A, concomitant carbamazepine use, omeprazole, PRN, heartburn use, C, occasionally missing evening doses, D, taking it with food, or E, all of the above. So I'll give you guys a few seconds to put in your answers. And I don't think I can see the chat. Okay, assuming folks put in their answers in the chat and you guys got it all right, it's E, all of the above. So these could all contribute to a suboptimal response. And then also, I didn't mention this, but nilotinib is a CYP3A4 substrate. So keep in mind when using CYP inducers like carbamazepine to think about the metabolism and potential drug interactions. So moving on to JAK inhibitors, we'll start with ruxolitinib. Ruxolitinib is the first approved JAK inhibitor. It inhibits both JAK1 and JAK2. The JAK-STAT pathway leads to expression of cytokines and gene expression important in hematopoiesis and immune function. It is metabolized through CYP3A4 with urinary excretion of active metabolites, and this one does require renal dose adjustments for a creatinine clearance less than 60. There are multiple indications for use for ruxolitinib, and the dosing is dependent on that indication. So in myelofibrosis, you'll typically see higher doses of Ruxol used, so anywhere from 50 to 20 milligrams twice a day, depending on the platelet count at initiation. And polycythemia vera, an initial starting dose is 10 milligrams twice a day. In steroid refractory acute GVHD, the starting dose is 5 twice a day, but could be increased to 10 twice a day as long as there's tolerance from a heme perspective after a few days. And then for chronic GVHD, the starting dose is 10 milligrams twice a day. For other 3 agents, fedratinib, pacritinib, and momelotinib. For fedratinib, this one is a JAK2 selective inhibitor used in myelofibrosis. It's dosed at 400 milligrams once a day. All of these are hepatically metabolized via CYP3A4, with fedratinib having some renal excretion as well. Fedratinib carries a warning for Wernicke's encephalopathy, and so we must check and replete thiamine prior to initiation, and that is built into the treatment plans. For pacritinib, this is also JAK2 selective, used in myelofibrosis, but specifically in patients with platelets less than 50. This one is dosed twice a day. And then some warnings that it carries are hemorrhage and QT prolongation. And then for momelotinib, this one targets both JAK1 and JAK2, so similar to ruxolitinib, used again in myelofibrosis, but specifically in patients with anemia. This one's once a day, and then this one's sort of interesting. This one does have an active metabolite that has about 40% of the pharmacologic activity. Warnings with this one would be infection and hepatotoxicity. All of these agents also carry a risk for major adverse cardiovascular events, particularly in patients with pre-existing cardiovascular risk factors. And then thinking about adverse effects for these, anemia is quite common, not in momelotinib, as we talked about. This is used for patients specifically with anemia, but quite a high incidence reported with ruxolitinib as well. Thrombocytopenia as well. You'll see a higher incidence with the pacritinib, but keep in mind this is approved for patients with platelets less than 50, and so those patients were included in the studies. Neutropenia is also a risk. Diarrhea will be more of a significant risk with our fedratinib and pacritinib agents, as is nausea, and then waking is associated with the ruxolitinib use, more longer-term use. Moving on to FLT3 inhibitors, we'll cover midostaurin, gilteritinib, and quizartinib. So FLT3 is FMS-like tyrosine kinase 3. The FLT3 receptor has an important role in hematopoietic survival and proliferation. There's two types of mutations. You can have an ITD mutation, so a mutation in the internal tandem duplication region, or a TKD mutation, which is a mutation in the tyrosine kinase domain. And then our inhibitors are separated between first and second generation. So first generation will be midostaurin, which is more applicable to leukemias. And these are non-specific, and they'll also hit many other downstream receptors. Whereas second generation agents like gilteritinib and quizartinib are more potent and selective for FLT3. We have type 1 inhibitors that inhibit both ITD and TKD, so that'll be midostaurin and gilteritinib. And then we have type 2 inhibitors that are not effective against the TKD region and only against the ITD, so that'll be quizartinib. So starting with midostaurin, this one is approved for newly diagnosed FLT3 positive AML, both in the induction and consolidation setting. This one is also approved at higher doses in mast cell leukemia and systemic mastocytosis. This is dosed at 50 milligrams. In leukemia, this is dosed at 50 milligrams twice a day on days 8 through 21 of the induction and consolidation phases. It's hepatically metabolized and does carry a higher risk for nausea and diarrhea. Other significant adverse effects to be monitoring for would be pneumonitis and QTc prolongation. Quizartinib is a bit newer. This one, again, is only targeted towards FLT3 ITD, so approved in that space, in combination with induction, consolidation, and also can be used in the post-transplant maintenance setting. A little bit more of a unique dose, it's 35.4 milligrams once daily for 14 days total during induction and consolidation. And then we used in a maintenance, the package insert will give guidance on how to escalate that dose in the maintenance setting. This one, again, is hepatically metabolized, carries similar GI toxicities, but also an additional risk for transaminitis. There is a significant risk for QTc prolongation, and so there is a REMS program associated with this drug for QT prolongation. Gilteritinib, approved for use for relapsed or refractory FLT3 positive AML. It's dosed at 120 milligrams once daily. Unless you're on a strong CYP inhibitor like POSA, then we would reduce the dose. Hepatically metabolized and carries similar risks as is with quizartinib, but a higher risk for transaminitis. And this one does also have warnings for pancreatitis and QTc prolongation as well. I'll mention with gilteritinib, we are seeing more of this used in the post-transplant maintenance setting, as there has been data to show a higher relapse-free survival compared to placebo, especially in patients with a detectable FLT3 ITD, MRD pre or post-transplant. So moving on to IDH inhibitors, we'll review enasidenib, ivosidenib, and olutasidenib. Vorasidenib will not cover, but it is approved for use in CNS malignancies, so that may be covered later on in the series. So IDH is isocitrate dehydrogenase. The mutant variety results in the inability of the cells to differentiate, and then you get accumulation of leukemic blasts. There are two isoforms of this, IDH1 and IDH2, and they both function in different parts of the cell, so the mitochondria or the cytoplasm. But both mutant clones result in increased R2 hydroxyglutarate formation, and the R2 hydroxyglutarate inhibits alpha ketoglutarate dependent enzymes, which then results in impaired differentiation. So starting with ivosidenib, this one is targeted towards IDH1, approved for use in IDH1 AML, newly diagnosed and relapsed refractory and MDS. It's dosed once a day, hepatically metabolized, and has GI toxicities, so nausea and diarrhea. And then these agents will all have a risk for differentiation syndrome. Thinking about the mechanism where we're promoting differentiation, that makes sense. And then also a risk for elevated bilirubin. This one does carry a warning for Guillain-Barré as well. Olutasidenib, not as commonly used, but also approved for IDH1 positive relapse refractory AML. This is dosed twice a day on an empty stomach. So again, thinking about adherence for a twice daily drug on an empty stomach, that's a bit more difficult. Hepatically metabolized, it does have a risk for nausea and differentiation syndrome and a little bit higher risk for hepatotoxicity and does carry a risk for hepatotoxicity. And then enasidenib will be our IDH2 directed therapy approved for use in IDH2 mutated AML in the relapse refractory space. It's dosed once daily. It's metabolized by multiple CYP enzymes. Similar risk for GI toxicities, differentiation syndrome, and then a higher risk for elevated bilirubin and hepatotoxicity. These agents also do carry a warning for QT prolongation and then again for differentiation syndrome. So differentiation syndrome, it does occur due to rapid proliferation and differentiation of myeloid cells. Symptoms would include dyspnea, pulmonary infiltrates, pleural effusion, renal impairment, fever, edema, and rapid weight gain. And these are the percentages here reported with the enasidenib package insert. The onset could be anywhere from 10 days to 5 months. And for treatment of differentiation syndrome, that would be treated with dexamethasone twice daily until symptom resolution. Retinoic acid derivatives, that would really just be tretinoin. So tretinoin, also referred to as all-trans retinoic acid or ATRA. I think we very commonly use ATRA to refer to tretinoin. This is used in APML. The mechanism is that this is a differentiating agent. It is dosed based on BSA, so it is twice a day. The duration does decrease with subsequent cycles, and these are available in 10 milligram capsules. So somebody might be taking 4 to 5 capsules twice a day when taking tretinoin. This is hepatically metabolized, and there are no adjustments for renal or hepatic dysfunction. This one, knowing that this is a differentiating agent, this does have a risk for differentiation syndrome. And so people starting on treatment do get prednisone for prophylaxis at 0.5 mg per kilo daily. And if they were to have at differentiation syndrome, again, we would start dexamethasone twice daily until symptom resolution. Quite a high risk for elevated cholesterol and triglycerides as well. And so that may even require pharmacologic therapy while they're on tretinoin therapy. And then a high risk for LFT abnormalities that's also monitored. The tricky thing with tretinoin toxicity is that tretinoin is really the only agent within this class and there's no alternatives. So in a disease that's highly curable, we really do try to keep patients on therapy and manage side effects with this one. Moving on to our new class of drugs, menin inhibitors, we'll cover revumenib. I will not cover ziftomenib since that's not FDA approved yet, but it does have a breakthrough therapy designation, so perhaps next year we'll cover this one. A little bit about menin inhibitors. So menin acts as a scaffold protein and facilitates the assembly of transcriptional complexes to upregulate oncogenic gene expression. And notably, we're talking about HOXA and MEIS1. Lysine methyltransferase 2A, also known as KMT2A, is a histone methyltransferase involved in gene expression regulation. And in KMT2A rearranged AML, menin is crucial for this KMT2A fusion protein binding to promote leukemic proliferation. So menin inhibitors disrupt the menin and KMT2A interaction to downregulate oncogenic gene expression and therefore promote differentiation and apoptosis. I will call out that NPM1 mutated AML is involved in this signaling pathway, and NPM1 inhibitors like ziftomenib would have a similar mechanism of action. So a little bit about revumenib. It's currently approved for use in relapsed refractory AML with KMT2A rearrangement in adults and pediatrics, so children's 1 year old or greater. If a patient is greater than 40 kilos, the dose would be 270 milligrams twice daily on an empty stomach. And then for mostly our peds patients or other patients weighing less than 40 kilos, it is dosed based on BSA, again, twice daily on an empty stomach. A couple of dosing considerations. So there are dose reductions warranted when used with strong CYP3 inhibitors, and that is called out in the package insert. So I'll direct you there if starting something like posaconazole or voriconazole. This one does have multiple tablet strengths available, 160, 110, and 25. So looking at the dosing, it's possible somebody may require two different tablet strengths for this medication. So another thing to think about when prescribing and educating on the drug. It is hepatically metabolized, no renal or hepatic dysfunction adjustments needed. Adverse effects, hemorrhage, nausea is quite common at 51%, musculoskeletal pain, and infection. There are warnings with this one for QTC prolongation and differentiation syndrome, and so this one is another one that requires an EKG at baseline. And this is, of course, a first-in-class drug. This is the first drug approved in the menin inhibitor class. And that is what I have. In the interest of time, if you have any questions, you can send me an email. My email's on the screen, and then I'll turn it over to Cam for the second half of the hour. Thank you.
Thanks a lot, Harpreet. As Mike said, I'll be presenting on cell therapies today. My name's Cam Ninos. I'm the cell therapy pharmacist, so really focusing on CAR T, TILs, and some of the other fun things we'll be talking about today. We'll go ahead and get started then. Our objectives are reviewing the manufacturing process for some of our cell therapies, and then looking at common toxicities and management strategies. Today, due to time, we'll focus on CRS and ICANS, and then trying to talk a little bit about some new initiatives that we have internally at the institution, which include outpatient grade 1 CRS management, as well as interleukin-2 management for our new lifileucel agent. So at a basic level, chimeric antigen receptor therapy involves harvesting a patient's T cells and then introducing that chimeric antigen receptor. So chimeric because it has parts that are human and stimulatory and co-stimulatory domains, as well as parts that are intended to bind the receptor. So it's this merger of a couple different concepts into a single receptor that's then introduced to a CAR T cell, and that's where we get the word origins for CAR T cell. The big advantage of it being that this is a living drug, so it's something that can continue to replicate within a patient and provide that continued tumor kill and active surveillance. So from a mechanistic standpoint for how this process works, like I said, it does involve a patient's own T cells. So all our current CAR Ts are autologous, meaning that patients do need to be leukapheresed in order to harvest those T cells. Those cells are then manufactured and reprogrammed to introduce our chimeric antigen receptor via viral vector. I do think manufacturing is a good term to call out here because it is something that we see product failures on. Different manufacturers have different time to delivery rates. And so it isn't something that has 100% success rate and always comes back in 14 days. But as our treating team needs to be thinking about how are we handling patients and keeping their disease stable during that manufacturing process. The cells are expanded in culture. They call it a cytokine stew with tons of interferon gamma, things like that produce this robust cell expansion once they get reinfused. Patients do receive lymphodepleting chemotherapy, so fludarabine and cyclophosphamide and all the agents currently approved, followed by the cell reinfusion. So this diagram or this table combines a lot of information, but I must say it is quite impressive in terms of, I think, the most comprehensive data on CAR T that I've really seen available. I think things to call out here. So we have our agents on the left, looking at our target. That's going to give you at least a loose idea of what malignancy we're going to be targeting. And then some of this cytokine release neurologic toxicity information, I think, for these agents is really helpful. So to start out, our CD19 products are going to be targeted towards leukemias and lymphomas, versus our BCMA products are going to be targeted towards multiple myeloma. And I should call out, shortly after this article was published last year, obe-cel or Aucatzyl was approved in adult ALL, and we're really hoping to onboard that in the next couple of months here. So looking at our indications, Tisacel I really think is a pediatric product now. We don't really see much use in large cell lymphoma or follicular, but our peds group, that is still their preferred product. Whenever we look at DLBCL, our main products are going to be Axicel and Lysacel. Brexacel still hangs around for some mantle cell lymphoma patients, though it does compete with Lysacel. And then that's our current adult BALL product that we're really hoping will be replaced by Obacel. And then on the myeloma side, we have Idacel and Ciltacel both approved. Trying to call out which products might have a little more toxicity. I think Axicel and Brexacel are our standouts for the wrong reasons. And these both do have a unique co-stimulatory domain that's CD28. And they are both made by the manufacturer is another way that makes it easier for me to remember them. And so I think the big call out here, because you'll see different products have high rates of CRS, but like our myeloma products, for example, have really high rates of grade 1 CRS. And that doesn't concern me especially much. The thing that's concerning with Axicel and Brexacel is they have really high rates of high-grade neurologic toxicity. So whenever we look at Brexacel, it was 4 out of the 5 patients we've infused for adult ALL have ended up in the ICU. I think they've had a median length of stay over 20 days. So those are the two I really think of in terms of severe neurotoxicity, especially, and just overall higher toxicity products. Ciltacel also, I think, deserves a call out, even though this diagram might not express it, just in terms of having a unique class of toxicities associated with it. So it has been associated with Parkinsonianism, which Idacel has had a couple case reports, but Ciltacel occurs more commonly with. And then this also seems to have higher rates of things like malignancy-associated MDS, some prolonged cytopenias. So definitely one that our docs think about who are good candidates for Ciltacel prior to infusing it, and we need to be careful monitoring for our toxicities. I really like this diagram in terms of just pulling a lot of information into a single picture. Like I said, for today, we're going to really focus on cytokine release syndrome and immune effector cell-associated neurotoxicity syndrome, or ICANS. But these other toxicities are things that could each independently deserve their own hour-long lecture and are things that are important components of our CAR-T monitoring process. So starting out with cytokine release syndrome, otherwise known as CRS, which is really a cadre of inflammatory symptoms that relate to cytokine elevations. Like I said, those cells are grown in that cytokine stew that gets them very revved up so that you get this very robust expansion whenever they're reinfused, especially following lymphodepleting chemotherapy. So it is correlated with things like, I think the biggest thing we've given attention to is the malignancy burden. I think especially thinking about like our myeloma docs, I feel like over the past 2 years, they've really begun to more aggressively cytoreduce patients prior to cell infusion. So that is something that we do have some influence over and our docs pay attention to. The nice thing about CRS is that it does give you a warning signal, which is fever, that tends to be the first sign at onset. And symptoms do tend to be mild, but they can progress from there. And then looking at our grading scale, ASTCT about 5 years ago now released the official grading scale that's the dogma for this. Fever is going to be our first warning sign, and that qualifies as just grade 1. The higher grades are all going to be according to whether or not a patient is hypotensive or hypoxic. Grade 2 is if they're responsive to kind of low-level interventions, such as fluids or low-flow nasal cannula, with grade 3 and 4 requiring things like vasopressors or potentially like intubation for the hypoxia criteria. Here's our institutional CRS algorithm. I think things to call out here is that for grade 1, you can consider tocilizumab with or without dexamethasone. I would say institutionally, our docs have been more aggressive in terms of administering those interventions, even though the evidence really hasn't there's not a ton of evidence for that yet, so I think that's going to be continued area of discussion. But in general, we have tended towards tocilizumab with or without Dex for even grade 1 CRS. As you move up the grading scale, we're going to start, most patients have already gotten tocilizumab, or we can redose up to 3 doses in 24 hours, 4 doses per course. I do think once you get about 2 to 3 doses in, we do need to start thinking about other interventions, because I don't think we're suddenly going to get a big response after a patient's received that many doses. The dexamethasone dose, then, you can see does begin to escalate as you move from grade 2, 10Q12, to grade 3, 10Q6, and grade 4, 20Q6. So there's a nice stepwise ladder for that. And then as we max out our steroid doses, we start thinking about other interventions, and the main one that's really coming to the forefront is anakinra, which we don't need to use a ton of for CRS. We use a lot more of it for ICANS, but that would be our next step, as well as high-dose steroid, which would be the 1 gram of Medrol. So the new thing that we just launched this past month is outpatient grade 1 CRS management for CAR T recipients. So we're still hoping to identify our first patient for this soon. I think one big call out is this is different than our outpatient management algorithm for bispecific antibody treatment. So if a patient received a bispecific, they might have been sent home with PRN steroids and instructed to take the step at home, or the steroids at home. Because the CAR T CRS does tend to be higher grade, those patients all require, or our CAR T patients all require being assessed in clinic. So if you get a call as a fellow or APP on this, I would just make sure you're differentiating CRS. Is it a CAR T patient or is it a bispecific patient? I do have just our basic outpatient treatment criteria listed here. I think the biggest one that's going to cut out a lot of our patients is they can't be neutropenic, because that requires neutropenic fever admission and treatment. So I think that's going to exclude a lot of our folks. And then I think just emphasizing it's grade 1 only. They can't be having neurologic symptoms. Our high-risk our products with Axicell and Brexacell are excluded from this process. And then there is just kind of a clinical judgment criteria about if they're wheelchair bound or something like that. It might not be the best candidate. Here's kind of a brief high-level overview. Right now, it's just in clinic, so 8 to 5 p.m., Monday through Friday. We are hoping to expand that at some point. And then patients are assessed for stability, meeting outpatient criteria, getting labs done. Then they might get tocilizumab and Tylenol with or without Dex in either the chemo room and infusion center, and get monitored for 4 hours before they get sent out. That brings us to the other big box CAR T toxicity, which is immune effector cell-associated neurotoxicity syndrome, otherwise known as ICANS. This can happen days to weeks after the CAR T infusion, and is thought to be due to cytokine diffusion into the brain, where it's thought that your blood-brain barrier integrity actually breaks down a little bit and permits additional cell trafficking, as well as cytokine permeation into the CNS. Presentation can vary. It can include things like headache and tremor to start, with more severe things like seizure, delirium, cerebral edema at its most severe manifestations. This is a 2-part grading scale. So the first part is the ICE score, or the immune effector cell associated encephalopathy score. The criteria for this are orientation, naming objects, following a command, writing a sentence, and then being able to count backwards. And then that gives you a 1 to 10 score that we then plug in to the overall ICANS grading. And the benefit of the score really is being able to identify these lower grade patients. Once patients start to escalate to higher grade ICANS, that's where their level of consciousness, presence of seizure might be driving your grading scale more so than the ICE assessment. So the ICE assessment is something we do all the time in clinic, and we do have nurses assess patients regularly. And the benefit is that earlier identification for patients who might just be getting to manifest neurotoxicity, so that we can intervene. I will call out pediatrics has their own ICANS grading scale in case you practice in that area. So from an ICANS management standpoint, the big call out is that tocilizumab doesn't penetrate the CNS. So in solitary ICANS without the presence of CRS, there's no role for tocilizumab in this management algorithm. And that means we're really going to rely on steroids as our first line therapy, which we start even for grade 1 at slightly higher escalating doses as patients move up the algorithm. And then anakinra has really stepped in as our standard second line therapy. So even for grade 2, we can start thinking about that. In grade 3, we would be administering anakinra. The other newer kid on the block from an intervention standpoint is intrathecal hydrocortisone with or without chemotherapy, which you can see we're considering at grade 2, administering at grade 3. And there's less robust evidence for this. It's all these smaller 5 to 20 patient kind of single center trials. But I think we have seen good, or in my opinion, I think we've seen good responses with it. And so I think especially once someone gets to Dex plus anakinra, it's something that we should be thinking about, even though there can be administration challenges if patients are having neurologic difficulties. You can see the ICANS management algorithm here. I won't linger on it though, just for time purposes. Thinking about other CAR T toxicities, just briefly, these are the ones I mentioned earlier. We have had some really challenging cases of immune effector cell-associated hemophagocytic lymphohistiocytosis-like syndrome, otherwise known as IECHS, so like CAR T-associated HLH. So this is a hyperinflammatory syndrome. It's associated with cytopenias, elevated ferritin, and coagulopathy, along with a wealth of other complications. It is independent from CRS and ICANS, even though it does tend to follow it. So there's a pretty typical time course where anywhere from 2 days to maybe a couple weeks after CRS resolves, you can all of a sudden see this inflammatory marker spike with cytopenias. And that can be the onset of this IECHS. It is really challenging to manage because my experience is it tends to be a lot more chronic and long-lasting than CRS, which tends to run its course relatively quickly. IECHS is managed with corticosteroids and/or anakinra. And so hopefully that's something you don't have to see, but the more CAR Ts we're administering, we are seeing that pop up more and more often, and it is definitely a challenge for us. We also can see prolonged cytopenias from these patients, so-called ICAT, immune effector cell-associated hematotoxicity. So for longer term, that's something we'll be monitoring for these patients. And then given that we're administering them fludarabine and lymphodepleting chemotherapy, they do tend to be neutropenic. And so, the CAR T itself with how it attacks the CD19 or BCMA cells can induce its own immunosuppression. So something that definitely can be patients can develop infectious complications. So thinking about things like antimicrobial prophylaxis, growth factor in spots, even though the exact place for that is still being determined, IVIG replacement, and then these patients do undergo revaccination similar to our stem cell transplant population. Then moving to some of the therapies we're hoping to onboard in the next couple months here is a bit of a preview or primer of what's coming. We have tumor-infiltrating lymphocytes and high-dose interleukin-2. So this is lifileucel, brand name Amtagvi, which was the first FDA-approved solid tumor cell therapy for unresectable or metastatic melanoma after treatment with a PD-1 inhibitor and, if qualifying, a BRAF inhibitor. Here, so this process looks pretty similar to CAR T. I think the main differentiator is that this is a tumor resection in the OR. So they're taking out a chunk of tumor, and then the TILs are actually isolated from the tumor. So there's no viral vector introducing a single receptor. It's really identifying these cells that are reactive against the tumor and then expanding them in culture. That's then shipped back to the center. Patient gets lymphodepleting chemotherapy. But because those cells aren't quite as activated as CAR T cells on their own, we do administer IL-2 afterwards. to try to wake them up and induce a greater anti-tumor response. So the complications for this are largely going to originate with IL-2 and chemotherapy administration, not as much from the TIL themselves. And to dive into that administration process in a bit more detail, I think callouts that are unique or different from CAR T are the cyclophosphamide dose is 60 milligrams per kilogram per day versus like the 300 milligrams per meter squared per day that we give with CAR T. So this is something that's closer to our like post-transplant cyclophosphamide dose. So definitely more intensive lymphodepleting chemotherapy than what we see on the CAR T side. Then we have that lifileucel infusion followed by interleukin-2 administration. And this is high-dose interleukin-2, similar to what you guys might have heard of, has been administered in probably about a decade ago for like renal cell or melanoma. The big difference here, the dose is the same at the 600,000 units per kilo. The course is shorter, so they would administer up to 14 doses, which I've been told no one ever finished because they got too much toxicity. Here they cap it at 6 doses, and then patients need to be monitored inpatient during that IL-2 administration. So like I said, IL-2 is really to enhance the T cell activity following the TIL infusion. The correlation between how much of a boost of effect you get and how many doses of IL-2 you've received is not that clear or well defined. There's some controversy there, which means whenever we start seeing side effects of the IL-2, we're going to err on the side of holding a dose. Because this is not CRS or ICANS driven, tocilizumab and corticosteroids are to be avoided. The manufacturer does say to avoid corticosteroids for 60 days post-infusion because they're concerned for risk of that TIL suppression and suppressing our anti-tumor effect, which is something we've seen for, especially whenever a lot of new immune therapies enter the market before we understand how they behave in the setting of corticosteroids. The side effects for IL-2, really, it can affect any organ system. So hypotension, GI discomfort, neurologic issues, fluid issues are going to be a focus, and then things like LFT abnormalities or kidney injury. And then there were a number of deaths on the IL-2 trial. I want to say 5 out of 30 or so, I can't remember. But so deaths on the trial were attributed to progressive disease, pneumonia, arrhythmia, and respiratory failure and hemorrhage. So this is a significant therapy that we really need to watch patients closely, and that's why hospitalization is going to be required. From a supportive care standpoint, then fluid status is going to be a focus because the IL-2 can throw off your fluid balance. And then discontinuing antihypertensives and administering anti-inflammatories and GI acid reduction with pantoprazole or famotidine. Monitoring is quite intense, although these patients will be on B66 to start, vitals, pulse ox telemetry, and then strict intake and output. And then you can see some of the other monitoring there. And the image for how this will happen is that we'll have a nurse check 2 hours prior to IL-2 dose administration. That'll kind of then she'll touch base with the treating team to decide whether to go or hold on the dose. For time purposes, I'm not going to go through every single management step here, but it is largely supportive, I would say. More specific toxicities that we can see with the IL-2. And then criteria to skip dose. So this is what the team is assessing at that check-in prior to each administration. And this is bisected into relative and absolute criteria. If this interests you, I would reference you to the Warner guideline that's cited at the bottom. That's kind of the standard for this. The idea is that if a patient has any relative criteria, we could think about holding a dose. If they have 3 or more criteria, it would be recommended to hold. And then any absolute criteria, so things like profuse diarrhea output, hallucinations, oxygen supplementation or intubation, signs of renal failure, things that we would stop the course for. Doses may be skipped or omitted. They're not reduced or delayed. If a patient does have those toxicity criteria, we should be holding the dose. And then we can't, if it's one dose that's skipped, we can get back on track with the next one if a patient recovers by the time the next dose is due. However, if 2 consecutive doses are held, the recommendation is to discontinue the IL-2 course. Just a brief sample of other next-gen immune effector cells we're onboarding. So gene therapy, Exocel and Lovacell are approved for sickle cell. These in different ways result in a functional hemoglobin gene for stem cells. They do require myeloablative conditioning with busulfan and a prolonged hospitalization afterwards. And so institutionally, we're hoping to onboard Exocel in the first part of next year. Sometimes a picture is worth 1,000 words, so this is just quite an impressive waterfall plot that Dr. Eckridge, who's our physician champion on the pediatric side, is very excited about onboarding this therapy and really wants to demonstrate how effective it has been. And so you can see in the primary outcome of the trial, 29 of 30 patients who were having very frequent vaso-occlusive crises beforehand we're able to go at least 12 months without an incident following infusion. So very excited to be able to onboard this therapy in the coming year, and we can stay tuned for that. That's the thanks for your time on reviewing the cell therapies. I'd be happy to take any questions if you have them.